One.
Hi everyone, welcome. We got a great case today. So let's start.
So this is a 73-year-old male.
Hold on 1 second. So 73, let me write it over here. 73-year-old male, female?
Male.
Okay.
Presented to the ED with chest pain.
With the complaint of chest pain. Okay. So, when patient come with a chest pain, everything we ask, what's the first question we ask? Rule out emergency. What could kill a patient, right? That's the most important thing in my mind. And you're a doctor or somebody call you and say, like, I got somebody with chest pain. My goal is to make sure what's the emergency, which I have like 2 to 3 hours kind of act on it, right? So which conditions, what are the emergency in somebody with chest pain? What are the emergencies?
MI.
MI. What type of MI?
STEMI.
Okay, is non-STEMI an emergency? Not as bad as STEMI, right? Why is it STEMI? Because you have to do this door to balloon time. You take them, take over and do a cardiac catheterization, remove the block, otherwise they're going to die. Mortality rate is very high. So chest pain, STEMI is my priority to rule it out. Okay, what else?
Pulmonary embolism.
Pulmonary embolism, yeah. If you don't act on it like right away, I see this all the time. The patient come in, chest pain, it's usually have like shortness of breath. People can miss that easily and the consequences like extremely high. The patients are going to die, okay? So, so talk about myocardial infarction, we talk about pulmonary embolism. What else is an emergency?
Aortic dissection.
Aortic dissection, right? Don't give you, that's the one you have to call surgeon right away. The patient could be dying like within what, 20, 30, even faster, hypotension, you're gone. So you need to rush them to the OR. What else? What else would kill the major thing?
Pneumothorax.
What type of, regular pneumothorax, not really. What tension pneumothorax,
Tension,
right? If you
okay.
don't act on it right away, they're going to die. Okay. Or if you have like cardiac tamponade, right? Something, all those kind of things will call. So that is my first thing before. When somebody come with the chest pain, that's my goal to make sure. There anything else I ask myself, is there an emergency I'm missing? Is there something I have to act on like 5 to 10 minutes? Okay? So when we talk about chest pain, let's talk a little bit about the differential diagnosis, right? So let's write it over here. We'll put some categories. One is heart, right? And the other one is what? Pulmonary.
Right.
Okay. What is the other?
GI could cause.
GI causes. We put GI. What else?
Costochondritis. Musculoskeletal.
Musculoskeletal. Okay. MK. We'll put that. What else?
Any neuro.
Neurogenic causes. What else? Psychiatric, right? The last one. Never pick this as the first one. Okay? You rule out everything. Don't get into the habit of labeling the patient. The patient, is a psychiatric history. He's making up worst mistake he can make. I've seen this people do all the time. Please don't do that. Your job is to make sure what is the emergency and then work your way through and then you rule it out. Then you say maybe some psychiatric component to it. Okay? So when we talk about the heart, what are the things we have to, of course we have to worry about MI. Okay, and we talk about the difference between the STEMI and non-STEMI, right? What are the major difference between STEMI and non-STEMI?
ECG findings.
EKG finding, of course, that's everybody know. It's clear. ST segment elevation MI, non-ST segment elevation MI. What else? What are the major other difference?
Components of the plaque.
Okay, usually like in non-STEMI is what? More like a platelets is the one kind of causing. The other one, when you look at the, STEMI is like fibrin, even those platelets is there, and that's why you use like the fibrinolytic or thrombolytic, thrombus formation, okay? And then when you look at the blockage, most of the STEMI is what? Almost like 99 to 100% blockage. Yes. When you look at what about STEMI? Non-STEMI. Maybe like 40-50% and all that too. Okay, when you do, the other thing is like when you do a cardiac catheterization on these people, I mean, most of the non-STEMI, like sometimes they might not have a blockage, you have to act on it, okay? So which one, like, let's say the mortality, which one have the highest 30-day mortality?
STEMI.
STEMI has highest 30. Which one has the 1 year highest mortality, STEMI or non-STEMI?
Non-STEMI.
Non-STEMI, always
Okay.
remember that, okay?
Okay.
Once the 30 days over, and if it is 1 year, the long-term mortality is like, so the bottom line, don't ignore non-STEMI also. They're both emergencies, but immediate emergency when I talk about is STEMI. Okay, so we have to rule out the myocardial infarction. So when we talk about, I mean, and then what are the other cardiac causes?
CHF.
CHF can cause, you're right.
Pericarditis.
Okay, any kind of pericardium kind of involved in. We talk about the pericarditis.
Cardiac tamponade.
Let's talk about pericarditis. So, I mean, how do you, like, what is the major, like, I mean, what are the presentations usually pericarditis? Clinical presentation.
Sharp pain.
Like 4 or 5 days, what happens to them? What do they have?
Any viral
Viral infection. They usually have, like, 4 to 5 days before. Some kind of viral infection, upper respiratory infection or something kind of thing. That's when they usually kind of presentation, right? And then EKG finding, what are the EKG finding?
Diffuse ST segment.
Diffuse ST segment. What else? People always forget. I mean, everybody know, like, pericarditis, diffuse ST segment elevation. What is the other major thing?
sinus tachycardia.
PR segment depression.
Okay, yes.
Okay, start with the PR segment depression, diffuse ST segment elevation, and then ST T-wave ratio in lead V6 is also very significant, which we'll talk some other time. But those are the things we need to kind of worry about. On examination, you could have, like, the pericardial friction rib and all those kind of things. All right, what else? Myocarditis, right? We can put that in the category.
Right.
What are the major difference in the pericarditis and myocarditis? Of course, we said the EKG, but more troponin is more leaking pretty much in the myocarditis, okay? And then we talk about the valvular disorders. Which valvular disorders usually give, like, chest pain? Aortic stenosis is very common, okay? Severe aortic, not like, and then mitral valve prolapse also can have, like, chest pain. So if you have to think about 2 valvular disorders, I rather think about aortic stenosis and valvular diseases. What else?
Cardiac tamponade.
Cardiac tamponade. What else?
Any cocaine toxicity or something?
Yeah, that's very good. Like, I mean, anytime somebody have, like, what happens, like, I mean, cocaine, vasospasm can affect the myocardial vessels, myocardial angina, those kind of things. So it's good to know, like, what additional drugs they have taken, okay? So we talk about cardiac tamponade, we just say, like, cocaine. We also, the major thing we already talked about the vascular, right? Abdominal aortic dissection, right? Vascular, let's say AAA, we can write?
Yes.
Is that okay?
Right.
Right, and everybody's okay with that?
Yeah.
So all those kind of things, very, very important. We'll come back to the other thing. Pulmonary, what are the major causes we need to worry?
Pneumothorax.
Pneumothorax. I think I'll put pulmonary embolism as the first one.
Okay.
Pulmonary embolism is very important. What else? We talk about tension pneumothorax, right?
Yes.
Pneumothorax, which is tension pneumothorax. Okay. Anything else? Okay. And then GI,
Right.
gastroesophageal reflux disease, right?
Right.
Peptic ulcer, all those category.
Okay.
And perforation, right?
Yes.
Of esophagus. We need to worry. Musculoskeletal, any type of shoulder pain, those kind of thing, right? Kind of related to, like, anything kind of maybe muscular, any kind of muscle injury right here, we can say that. Yep.
Costochondritis.
Yeah, costochondritis. We can say rib fractures,
yes.
we can put in that category.
Right.
Neuro, what is the one we have to worry about? Neuropathic pain, what is that?
Herpes zoster.
Herpes zoster.
Herpes zoster. I seen this all the time, patient come with the chest pain what happens? Like everybody like, working on the EKG, all the other thing, giving aspirin, but they fail to examine the patient, right? They never one guy came in, they would do like 3-4 hours and all those kind of things, never examined the patient. Next day the cardiology came in and he examined the patient. He had like herpes zoster distribution and the pain was coming up there. So don't make that mistake. I've seen it all the time. We're going to look like a fool when you do that, right? It's very important to examine the patient. That's what it said that. Okay, and then you got the last one, maybe we can say the psychiatric causes, right? Patient is kind of like faking chest pain to get out of work or come to the, or like some other monetary reasons or something they are doing.
Anxiety,
like
panic disorder.
and the panic disorder and all that. So let's talk about a little bit about a chest pain when a patient come in, right? We know about myocardial infarction. So how do you know? I mean, again, we know we had everybody come with a chest pain, and you ask the patient, what are they worried about? Heart, right? They think I have a heart attack, right? That's what they come in. So we need to make sure the patient don't have any pain. So let's say we have 100 patients come to the emergency. How many of them had actually had like a chest pain? Like cardiac kind of chest pain? Just give me a number. What are the numbers?
60.
60% of 100?
30.
No way. That means all of them are going to be admitted in the hospital.
Right.
All right, how many?
30.
20.
Come on down. What else?
5%.
5% or less than that.
Okay.
Most of the time, patient come in, there's like chest pain. Everybody's like, my heart is gone, and they come in and say like, okay, I need to get investigated. Most of them are like gastroesophageal reflux disease or musculoskeletal. So if I had to put something most common, it's like gastroesophageal reflux disease. So before like somebody, let's say an ER doctor call you and said like, hey, I got a 90 or like 85-year-old come to with a chest pain in the emergency room. Before you walk into the room, I know, right? My chances of this guy having heart disease like less than 5%. Okay. Now, my next question is like, what kind of question, evidence-based medicine, to increase my odds from 5% to something else? Okay. You have a lot of questions we can ask about chest pain, right? Textbook. But we have to think a little bit more. Today's world, evidence-based medicine. Which symptoms are going to give you the highest likelihood ratio of increasing my odds of having chest pain? Okay, so we have to think about that, right? There's something called a positive likelihood ratio, which they use the sensitivity and specificity to calculate. There's something called a negative likelihood ratio. So now I know before I walk in, this patient is, how old is the patient? 73-year-old average, come to the emergency room, chest pain. Before I walk into the room, I know 5%. So what is the evidence-based medicine question I can ask this patient to increase my odds from 5% to 20%, 30%, 50% and all that? What kind of questions we can ask?
Radiation to...
Radiation, always kind of think about it. Okay, radiation to both shoulders. I mean, I think the likelihood ratio is around like 2 to 3. Radiation to right shoulder has the highest likelihood ratio, right? So like, I think it's gonna go to like 3 to 4. Left also have the highest likelihood ratio. So the first question I have asked, the pain radiate anywhere? What is the next question I'm going to ask?
Type of pain?
Not really.
Okay.
Okay, so I will ask about nausea. There's like nausea, vomiting have like a component, have a highest likelihood ratio questions and all that. Let's say this patient, so does this patient have, where's the chest pain radiator? That's my question. This patient, tell me, where's the pain radiating to?
To the left arm.
Okay, so tell me like the pain is radiating to the left arm. Based on my scientific knowledge, I'm going to say, I know before I walk in was 5%. When I walk in, he told me the pain radiate to the shoulder. I know he has highest likelihood ratio is around 3. My odds of having this guy having chest pain, cardiac chest pain, has gone up to 20 to 25% now. Okay, so that's like good question. Now, there's some questions we can ask to bring our odds down. What kind of questions we can ask? Like, let's say, I'm not talking about this patient. So you got like a patient come to the emergency room with chest pain. And then before you walk in is less than 5%. But I want to decrease that odds like less, so I don't have to do the $1 million workup. That's why value-based care. We waste a lot of money on chest pain. So what kind of questions we can ask?
History of drug abuse.
History of drug abuse, how can it be? You already said cocaine, right? We'll come back to that, right? That can cause odds are having high. So odds is a little bit higher when you said that, okay? if the pain is on palpation, okay, I remember kind of 3 P's. Remember, palpation. If the pain is reproducible by palpation, it goes down. Okay. If the pain is positional, somebody like, oh, I'm having pain, kind of moving and all that, that's also what goes down. Okay. Negative likelihood ratio, right? And then pleuritic chest pain. What is the pleuritic chest pain? On the patient, you ask the patient to take a deep breath, and the pain goes down. I mean, the pain increases, not doesn't go down, but odds go down when you have pleuritic. So remember, 3 P's, right? On palpation, positional, and pleuritic give you the highest negative likelihood ratio. Everybody got it? So the difference between positive likelihood ratio, bring the statistic, think like an odds maker, right? We know, like, I mean, what's going to happen. I mean, some of these approaches, you have to take the approach. When you go to casino, you ask, when you're playing blackjack, what are my odds of getting some of the money back? The same thing approach we should be using in diagnosing patient. Okay, today read everything about every patient comes in, like, what's the highest likelihood ratio of the symptoms again? What is the negative likelihood ratio of the symptoms? What is the positive likelihood ratio? Everybody got it? Okay. So when we talk about, so that's kind of very important. So what does this patient have?
This patient has associated palpitations.
Okay.
And the patient also has diaphoresis and nausea.
Okay, even we know, like, I mean, nausea is up there, my likelihood ratio, this is kind of high, right? So we talk about all this and then talk about the past medical history.
So he has a past medical history of atrial fibrillation, hypertension,
hypertension,
hyperlipidemia,
okay,
bipolar disorder, depression,
okay,
benign prostatic hypertrophy, and gout.
Okay, so we know he had history of hypertension. There's cardiac risk factors, right? Does he have hyperlipidemia also, or no?
Yes.
Hyperlipidemia? Okay, very good. So there is some risk factors, like we know. What is the next thing? Any allergies?
He is allergic to naproxen, NSAIDs, and penicillins.
Naproxen, NSAID, and
penicillin,
right? So we need to make sure, first thing I need to make sure, like, he's not allergic to aspirin, right? That's like a very bad sign. Like, somebody come in like chest pain, and you already know it's pain radiating, my risk is high, so that will be very important. So, I mean, family history, is it important?
Yes.
Why is that?
If there is any heart
disease, like, I mean, any heart disease, meaning if you have a relative who died, like, at a younger age, right? That's where I mean, if somebody, you got my grandfather or mother, like they're like 80, they have heart disease, is that a risk factor? Is that a risk factor? No.
Only at young
But
age.
only somebody have, like, and I have an uncle or like a relative less than 50 and all of a sudden have a heart attack and kind of died. That's what it is, the risk factor high. Okay? So what do you say about the family history? What do you say?
It's not significant, like
No significant history. Okay. And the medication, what medication?
So he was on phenazopyridine,
Okay.
famotidine,
Yep.
also on bupropion, rivaroxaban.
It's okay. Okay. We need to know that rivaroxaban, right? Why is that? Why do we need to know rivaroxaban?
If he has
The
any
patient
history
has,
of
like,
PE
huh?
or DVT.
Yeah, because I mean, I know, like, I mean, when you look at this patient with the PE and he's already on a anticoagulation, I can relax a little bit, right? So I can say he's anticoagulated. My differential diagnosis is very low because we already know he's getting anticoagulated. Remember that. What else?
He's also on atorvastatin.
He's on a statin.
Yeah.
What type of statin is atorvastatin? Hydrophobic or hydrophilic? Hydrophobic. Okay, remember, it's kind of like, it's good to know statins, like, what is one of the most common prescription in the world, right? I think the highest number of prescription after Viagra may be statin, I think, in the world. Okay, and rivaroxaban, statin, what else? Is he on aspirin?
No.
Why is that? Right? I mean, why is it important to us for the aspirin? Because we need to know, right?
Yes.
We need a risk assessment, all this, he was taking aspirin and all that too. All right, what else we need to know? Medication history, we talk about it, and then social history?
He was a former smoker. He quit smoking 30 years ago.
All right, so he's a positive smoker. Does he drink alcohol?
No.
Okay. no alcohol. We need to know, like, is he taking recreational drugs? We already talked about cocaine, right? Why is it important? How do you manage the difference? Is there a management in the difference? Somebody have a cocaine-induced myocardial infarction. What are the drugs? Two drugs is important.
Beta blockers.
No,
You don't give beta blockers.
Okay.
That's the
Benzodiazepines.
The
contraindication.
worst answer you can give. Okay. You have to be very careful when you give beta blocker to cocaine
Contraindication.
people. You can have like unopposed like alpha,
Right.
and it could go crazy. Just be
Benz.
careful. That's why you get a very good history in the when you take care of this patient. What other thing? Who said benzo?
Yes.
Benzo has a role in, and castellano blocker also
Right.
has a role in
Right.
it. Okay, so it's very important to know if the patient is taking any cocaine and all that too. So, and then we have sexual history is important. What is the sexual history in this patient?
It's not given on the file.
Okay, I mean, it's very, very important. If somebody present in the case, when you do an H&P, you're going to be in trouble, if you don't do systematic. You have to do an H&P like a textbook EKG. It's very important. Any other sexually transmitted diseases can cause like chest pain. In HIV patients, cardiac disease is extremely high. Okay. And then if you have like syphilis, like long term, like tertiary syphilis and all that can cause
Right.
like aorta, those kind of things, and dissection, all that kind of happen. So it's good to have a history like systematic. Psych history, we already said this patient has, right?
Depression and bipolar.
We already said like psych history, we can say. Depression, okay. Now, so we did a history, any other history we need to know? So based on this history, at this point, what's our differential diagnosis? Like number one, like what's our diagnosis?
Myocardial infarction.
Could be myocardial infarction. It's something related to cardiac, I would say
Right.
that, right? Because I would say the pain kind of radiated in the shoulder, there's associated with the nausea, and then he got history of smoking, your hypertension, hyperlipidemia. He's also what? 73-year-old male, right? Kind of also like put those. So examination, tell me the findings on the examination. So one more question. In the past medical history, what else, will give you highest likelihood ratio for a myocardial or cardiac chest pain? If the patient has a previous MI,
Yes.
okay, that give you the highest. That's very important. When you look at the symptoms, which will come back, which one give you highest likelihood ratio? Okay. All right. Let's look about the examination. Vital signs, the most important thing. What are we looking for? What are the vital signs? Tell me about the
The
vital
blood
signs.
pressure was 132/91.
132/91. Okay.
Temperature 96.1.
96.1. Okay.
Pulse 92.
92.
Respiratory rate 18.
18.
And oxygen saturation 95%.
95% saturation. Okay, so nothing kind of stand out, right? I mean, if I had to worry about a PE, usually they're tachypneic, they usually like hypoxic, right? But what is like when you talk about myocardial infarction or something, which one have highest likelihood ratio? Any of those symptoms? Again, we're going to positive likelihood ratio. If they are hypotension, if somebody with a chest pain, hypotension, most likely is cardiac, so the risk is extremely high. I think likelihood ratio go up to like 15 or 20, very high, okay? So be careful when somebody is hypotensive. Don't take it lying down. Okay, now we did this. Now we have to do the examination, right? So what examination is important in this patient? Like, let's think about what are we going to do? What do we need to know? What do we need to know?
Cardiovascular examination.
Is that what it is? Don't you have to look at the patient first?
Yes.
You're going to assume
Yeah.
only cardiovascular, right? We also said like a lot of differential
Yes.
diagnosis, right? What else we like when you look at the patient, what do we need to know?
Is the patient in any acute distress?
Acute distress, tension pneumothorax, like aortic dissection. It's kind of like patient look very, very sick, right? That's kind of very, very important also, right? What else?
General appearance, any sweating.
You're going to look for anemia?
discoloration.
And can anemia cause chest pain? That could be like one of the causes of chest pain. I think we
Yes.
didn't write it, hematological causes, right? Just order like hematology. Okay, so how do you check for anemia? Look for
Check for
pallor,
pallor.
right? That's important. And what else? In the ear, what is like, is there a relationship with ear examination? And there is, okay? You can see like, cardiovascular disease if you have thickening or like and all that.
Fat thing on the earlobe.
Yeah, earlobe, just kind of feel it. There is an increase in cardiac disease in this patient. And then come to the neck, what are we looking for? Of course, we have to look at like JVD, right? Okay, what else? In the other examination, anything else?
Yeah.
Okay, come to the lungs. You examine to make sure like, there's no decreased breath sounds or those kind of thing. And then if you take one again, likelihood ratio is high. If they found S3, the risk of MI or CHF is extremely high. So it's kind of hard to find, but you have to listen for S3. What else do we need to know? Right?
Yes.
We need to know any murmur, right? We already said like aortic stenosis is going to be like
Yes.
one of the causes, right? Didn't we say like aortic stenosis
Yes.
up here, cardiac vascular,
Right.
valvular, is put like aortic stenosis, mitral valve prolapse. What type of murmur you can have aortic stenosis?
Crescendo, decrescendo.
Systolic
Systolic
murmur,
murmur.
right? Usually already in the carotid, those kind of things is kind of very important, okay? So what was the examination finding? Anything?
Only on cardiovascular there was positive chest pain and palpitations.
Okay, so there is positive pain on palpation, right? So what did that tell us? That means, what did I say? Negative likelihood ratio, remember. So my odds has come down a little bit, not too much. This guy is still very high risk, right? If the pain on palpation is like negative likelihood ratio, I know that could come down. Okay, and then what are the labs we have to order in this patient? What are the labs? I'll start with.
CBC.
Okay, why is the CBC important?
Any infection, if
Huh?
at all, for
Any anemia?
anemia infection.
Anemia, definitely,
Yeah.
right? Anemia, we need to worry about, like, it can definitely cause chest pain, right? Is it, WBC is important to anything? What happens if you have a huge amount of WBC, right? It can cause stasis and all that, like malignancy kind of thing, right? If you have 100,000 and all that, the blood vessels kind of block, they can have like a myocardial infarction, stroke and all that is very common. Anemia, we need to know. Do you need to worry about polycythemia? Of course,
Yes.
that can
Yes.
also cause us like and all those kind of complications. Why do we need no platelets? Why is it important about the platelet? Because these people, when somebody with chest pain, right, if they have like thrombocytopenia, our management is all chest pain, cardiac kind of related, like thrombolytic, aspirin and all that. So we need to know that. So what are the labs? Tell me the numbers.
WBC is 4.7.
Okay.
Hemoglobin 12.5. Platelet 181.
181, so all good. So, what is the other, like the BMP, do we need to know?
Yes.
What are they?
Sodium is 138.
Okay,
Potassium 4.3.
okay,
Chloride 108. Bicarb 22.
okay.
BUN 22.
Mm-hmm.
Creatinine 1.16.
1.16. Okay,
And
so
glucose.
we also need to know, like, if there are metabolic acidosis, when there's like a cardiac ischemia, there is also the lactic acid elevated, then also we need to know that could cause, lactic acid, there's ischemia can cause like lactic acid over diagnosis, right? We have to know that. Why do we need to know renal failure when somebody with chest pain? Why is that?
Uremic pericarditis.
Yeah, that's like a very good thought. Like, okay, pericarditis, even though it's kind of rare, but that could happen. But, all these people, like, what is the management? These people, like, the management is what? You have to do cardiac catheterization, most of them. So you need to be careful, right? You need to know if there's like a renal failure, would you be able to cath them?
No, contrast.
Right?
Yeah.
It's not absolute, is it an absolute contraindication or relative contraindication?
Relative
Somebody
contraindication.
it's a relative contraindication. If the patient is dying with a have an MI, and if you have renal failure, you can also always do the dialysis, right? So there is an option, all that. So what are the other labs we need to check on this patient? What lab would you do?
Cardiac markers.
Cardiac markers. What are the markers?
Troponin
Okay, what is the troponin in this patient?
EKG.
0.09.
We'll come back. What is it?
0.09.
0.09. Did they do any serial EKG?
They did one, and it showed left anterior fascicular.
No, troponin. How many, like, do we need
So
to know
in
serial
first
troponin,
one-
or are you just happy with the one troponin?
No, initially it was 0.07 and then
Oh,
it was
okay. So I'm gonna
0.09.
change this 0.07.
07, yes, and after 0.09.
Why is that? What is that? Why should I worry about this?
I think it's worsening the.
What is it
ischemia
called?
is worsening.
Something called, what is it, the name?
Necrosis.
Delta troponin. Okay. So anytime you have increase from here to here, if you have delta troponin,
Right.
take it very seriously. My odds having things kind of gone up, right? Any other lab we need to do before we go any other lab?
BNP.
BNP? Okay, it's reasonable to have a BNP because it's cardiac chest pain, CHF. So I would definitely check it. Very good. What else?
INR.
INR. Why is it the patient is on rivaroxaban? Does it usually affect the INR? Not much.
Not much.
Okay, so just make sure, like, I don't think like INR is not like, you don't have to check at this point. Okay, let's look at the other investigation. What are the investigations you have to work?
EKG.
EKG, yeah. Okay. What are we looking for in the EKG? Which one will give you the highest likelihood ratio? ST segment elevation or not, right? The ST segment elevation, if it is high, our diagnosis is pretty much there. You take the patient to the cardiac cath lab, right? So what is the EKG on this patient? Always when you check the EKG, compare the previous EKG to this, okay? And because very important, the first thing, just like chest X-ray, when you have a chest X-ray, you always kind of go back and kind of talk about like what it is, okay? So what is the EKG finding?
Left anterior fascicular block.
Left anterior fascicular block. Okay, and then what else? What other investigation do we need to do? Anybody else? Come on.
Any albumin globulins, if at all?
Not really, not much. Did you do a fasting lipid profile in this patient? I haven't seen anybody kind of talk about it. Is it important to do fasting lipid profile?
Yes.
Usually, like, the reason I don't do it, because when you do in acute situation, the lab's kind of like completely messed up. So what I do is, like, I usually go back and check the patient's charts and see like what's going on there, right? And then that's the best way to do. Rather than like when a patient came in and all this kind of things going on in an acute situation, the cholesterol values will be like completely kind of messed up. Okay, remember that. Nobody said anything about chest X-ray. Should we check a chest X-ray?
Yes.
All right.
Yes.
What is a chest X-ray in this patient?
No significant findings.
So chest X-ray was within normal limits. Okay. What else? Anything else you can think of? Right? We're not suspecting PE, anything else, I kind of move on. So what is the number one? So we just have this patient, we summarize. We know based on our history and physical, what's our differential diagnosis? Number one is a cardiac, chest pain, or unstable angina we need to work. When we came up here, we have talked about there is a troponin leak already, which is delta troponin, right? And so there is EKG. I'm not too much what's going on right there. You have to compare it. So kind of give me an idea at this point. So based on all this, somebody tell me what is the diagnosis you're going to put it down. What is our number diagnosis, sir?
Chest pain.
Chest pain. Wrong. We have come all the way up here, right? We have talked about several differential diagnoses, right? When you have an assessment and plan, always do think what? Based on our assessment and plan, based on our likelihood ratio, based on our odds, we need to come with a diagnosis, not a symptom, right? When you said chest pain, we already talked about how many things can cause chest pain, right? So always put the diagnosis. So give me one diagnosis right now. What is that?
MI.
MI. What type of MI? STEMI, non-STEMI? I would just go with the non-STEMI, my friend. Right? So I write my diagnosis. Everybody agree with that? Or
Yes.
I don't want somebody, the bottom line, I don't want to see somebody write chest pain. You went to all this like discussion. I see people do that all the time. They write chest pain. I go crazy. I don't like it. So I write the diagnosis as non-STEMI. Okay? And the next thing I have to do, when you have somebody with a non-STEMI, I always do what? Risk assessment. What are the risk assessment to see, right? What are the risk assessment I have to do on this patient?
TIMI score?
TIMI risk score, very good. So somebody tell me, calculate the TIMI risk for me. TIMI risk. All right, I know like the age greater than 65 is like one of the component. Is already what?
73.
73. What else?
Gender, male.
Risk factors, right? Does he have risk factors?
Yes.
Smoker,
Yes.
hypertension, you got hyperlipidemia, it's already there's the risk factor there. Does the troponin is one of the component?
Yes.
Okay, so we know that. What other component is there? So what will be, somebody calculate and tell me what's the TIMI risk score?
2, 3.
Male
5.
gender.
5.
Yes.
Okay, male is also kind of, but only thing it is, I mean, one of the component is like, are they have taking aspirin or not? It's like less than 7 on think is important, okay? So TIMI risk score is 5. So what does that kind of tell me? My risk assessment, my risk is high for this patient, right? So what is the, I mean, what are the things we have to do? What medications we have to give him? We need to make sure what?
Aspirin.
Aspirin, right? You need to make sure what is he on? Beta blocker, right?
Yes.
What else is he on? A statin?
Yes.
Okay, we need to have statin. All of this kind of usual stuff, right? Pain control, maybe like IV morphine, even though it doesn't help that much with the mortality. I would put some PRN order to cover. Should I call cardiology right away? Am I going to pick up the phone and I'm going to say like, hey, jump in right here on this patient? That's the question. Do I have time to talk to the cardiology? Can I
No.
wait 30 minutes or can I, something, an emergency? Should I ask any of that?
Yes, maybe.
Huh?
We don't have
Why
any-
is that? It's a non-STEMI. You picked up the cardiologist and said like, hey, you know everything. Like, why did you call me? The cardiologist is going to ask like right away.
Right.
What is the management of non-STEMI? The main management. Okay, they need cardiac cath, but they don't need it right away. Like 5-10 years ago, all of this patient, they used to have like cardiac catheterization. Okay, when you have cardiac catheterization, when you have somebody with a non-STEMI, you have like 24 to 48 hours to do to the STEMI. You know, we already said, you know, we took the composition, right? The platelets, you got antiplatelet agent in them. You know, most of them, if you do a cardiac catheterization, only around 40 to 50% have, you know, like block is like half of the block, right? Not completely blocked, right? And the mortality is more high when? 1 year or 30 days? 1 year,
Yes.
right? So I will write, am I going to put a stat cardiology consult or regular? I just can put like a radial cardiology consult, right? Right? Anything else we need to think about in this patient, in the diagnosis? Agree with the management?
Yes.
Okay. All right. Thank you very much. Bye.